Okay, A&P1 students, in this video we are going to talk about the elbow joint and a few other specific joints in the body. So if you recall our objectives, learning objectives, we're going to talk about the different joints within the elbow and the various movements that it can make and why it's a pretty stable joint. And then we'll also talk about what a subluxation is, which can happen. So the elbow joint, there's actually a joint between the humerus and the radius and the humerus and the ulna. So they call them humeral ulnar joint and the humeral radial joint. So our little picture here shows the two bones there. So kind of a small picture. But here's our ulna, so it's forming a joint with humerus, so that's the humeral ulnar joint, and then on this side we have the humeral radial joint. So, all right, so that is the two joints that make up our elbow. So the movements that can happen, they show it up here, sorry. The movements that can happen at that elbow, generally it's just two movements where we flex, so that means we decrease the angle of that joint. So that elbow joint, and then extension where we increase the angle. So we pretty much can just flex and extend the elbow. So not as many movements as, say, compared to the shoulder, the glenohumeral joint, and those associated joints in there. We can have a lot. We can flex and extend there, but we can also abduct and adduct and rotate and circumduct, all kinds of other movements. So the elbow joint is a little bit more stable, so it has a little less range of motion. So it can just primarily do flexion and extension. So the reason being for that, for our elbow joint, the articular capsule is pretty thick, so that holds remember those are the structure of the articular capsule, like the fibrous part. It's there to kind of make sure the bones don't pull apart. So it's pretty thick and a little bit stronger than other joints. And then if you remember the humerus, I don't know if I have a good picture to show that, but remember the humerus, the ulna, at one end it's like a U shape at one end, and that U-shaped part of the ulna, it kind of interlocks with the bottom of our humerus. So we get like a nice, strong connection between those two bones. So they interlock very well with each other. So there's a lot of bony support there, as opposed to the glenohumeral joint, where it was more not good at interlocking of bones, but primarily it was all the soft tissues that were providing the stability, which they don't do as well of a job as the bone. So, and then there's a bunch of ligaments. Again, you don't have to know the names of the ligaments, but there's a bunch of ligaments also that are increasing the stability of that elbow joint as well. So because of the trade-off, we got more stability. We're going to have less mobility in this particular joint. So, all right. So the next thing that we'll talk about is subluxation. So there's a little box that talks about subluxation. So this is called an incomplete dislocation. So we do have some trauma, and the contact between the bone surfaces is altered, but they're not completely, moved or separated from each other. So it's more of a partial separation. So they still have some contact. It's just not the right kind of contact. So that can happen in many joints, but this is an example of it can happen in seems like the head of the radius can be subluxated pretty easily, especially in younger children. But that's what a subluxation is. So kind of like a partial or incomplete dislocation. So where the bones move out of place, but just not still touching each other. So, all right. So then our next joint is our hip joint, and the hip joint involves the head of the femur, and then the acetabulum of the os coxa bone. So recall, there's a little picture up here. So you're going to have to recall from lab. We have the head of the femur, which it was a much more pronounced and bony structure on that femur than like the head of the humerus. And then if you look at the os coxa bone, the acetabulum is a very, very deep depression in that os coxa. So it pretty much covers most of the head of the femur when the bones are connecting. So a lot different than the glenohumeral joint in the shoulder, where really the glenoid cavity couldn't, only covered less than half of the head of the humerus. So we have a much more stronger bony connection between these two parts of the bones at the hip joint. So we're going to have a lot more stability, and as compared to the glenohumeral joint, but not as much as, say, the elbow joint. So there's always a difference in the joints based on how stable they are, but always stability is going to cancel out some mobility, and less stability, you're going to get more mobility. So it does have more stability than the glenohumeral joint. So it's less mobile than that one, but it still has pretty good mobility, and it's there to support our weight. So that's kind of one reason why we don't want it to be less stable, because that's not going to. It's going to be harder for our ligaments and muscles and tendons to keep our hip joints stable. So we need that bony stability there, which we have. All right. And then the last joint we'll talk about is the ankle, or the talocrural joint. So in this one, our ankle joint. Oh, and we do have the knee joint in here, which we're not going to talk about that one because we talk about that one in more detail in lab. So that's why that one's not included for our lecture, because we'll get into a lot more detail about it in lab. Okay, so our ankle joint. So it also is made up of a couple of joints. So we have our talus bone, and when we have above that we have our tibia and our fibula. So the talus is going to form a joint with both the tibia and the fibula. So that's where we get our two joints that make up our ankle joint. And recall, we'll see if this picture shows this very well, but recall that at the end of the tibia and the fibula, we have these little bulges. So like on the end of the tibia, we have the medial malleolus, so it's there. And then on this side of the fibula, distal end of the fibula, is a little bulge. We call that the lateral malleolus. So those two, you'll notice that they come down here, and they're preventing the talus from sliding back and forth, because they kind of, one's keeping it in place on the medial side, the medial malleolus, and then the lateral malleolus is keeping it in place on the other side. So that way it doesn't slide side to side, that talus. So just helping to keep it in place. So that's one of our objectives, is to the two different joints. One's between the tibia and talus, and one's between the fibula and talus. And then the medial malleolus and lateral malleolus, their role is to keep that talus from sliding back and forth. And the movements that happen at the ankle, and you'll talk more about what these mean in lab, but you can point your toes down. Oh, sorry, over here. Point your toes down. They call that plantar flexion. And then you can also point your toes upward. That's dorsiflexion. So those are the two movements that happens at the ankle joint primarily. So it's a pretty stable joint, and so we do have some movements, but not as much as some other joints in the body. All right, and then the last thing we'll talk about is a sprain, and then we'll specifically talk about an ankle sprain, since this happens Everybody's probably sprained their ankle at least once in their lifetime. So a sprain is any time you stretch or tear ligaments, but you don't like fracture a bone and you don't like dislocate a joint. So anytime you have stretching or tearing of ligaments, they call that a sprain. And so when you have an ankle sprain, on the inside of your ankle, now I'm going to go to the picture here, so that'll probably help a little bit. Yeah, so you have ligaments. You don't have to know the names of the ligaments, but just realize you have ligaments that are on the medial side and this is on lateral side and then medial side of your foot or ankle. So the deltoid ligament, which again, I'm going to ask you that one, but just realize on the medial side, remember that the ligaments on the medial side of your ankle are very, very strong. So these are very, very strong, stronger than the ones on the lateral side. So most of the time, if you sprain your ankle, it's because you roll your ankle to the outside. So they call that inversion. So it's kind of where the bottom of your foot faces, towards the center of your body. And so when you do that, you can have a sprain. You can stretch those ligaments, and they do get stretched and damaged and torn. So they call that over inversion. So we normally can do an inversion with our feet or at our ankle. But if we overdo it, we're stretching those ligaments on the lateral side of our ankle, and they can be torn and stretched and damaged, and so that will cause pain and that'll require some healing time. Now, the eversion is where the bottom of our feet point to the sides, and that doesn't commonly happen because we have such strong ligaments that the ligaments on the medial side of inside of our ankle are so much stronger that it's very, very unlikely that we will have that type of sprain. So we usually don't sprain those because they're just so much stronger. And they're even, you could say stronger than the bones, because they will even, you'll get a fracture of the bone before you would actually get damage to those ligaments on the inside of the ankle. So pretty strong. So just remember that the most common cause of an ankle sprain is going to be that over inversion, that movement where you roll your ankle too far. So the bottom of your foot's facing towards the inside of your body. So, all right, so that is it for our objectives for our Chapter 9 articulation chapter. So I will see you later.